of the show for today. We're talking to Dr. Husseini, who is giving us some information in reference to African-American disparities across the state of Tennessee, dealing with some major health issues. And of course, Dr. Husseini, let's see if we can pick up where we left off the last time, dealing with African-American health disparities, and then move on to the national health policy and some of the other things that you like to talk about.
Yeah, in order to understand where how does this impact us directly, what I did was to narrow this whole focus down to what is happening in Davidson County. Mm-hmm. As you know, Davidson County is the mecca of healthcare industry. Okay. You got across the street from, if you look at the map, you will see where the population is, where TSU is, where HCA is located, where Vanderbilt is, where Meharry is. HCA and TSU are just about a mile apart. That's the biggest healthcare
disparity and
corporation available to us. And if they could work on that issue, help us to work on that issue, that will be really of great help. In order for us to really work in this area, what I did was to break down our morbidity rates for heart attacks and congestive heart failure and stroke in the Davidson County by zip code for both African Americans and for whites. Where do the people live and what is happening in those zip codes? So if you look at the first map on the heart attacks, you will see that in the zip code of 207, 208, 209, the rates are higher.
Okay.
This is where the black community is concentrated.
207, 8, and 9.
207, 208, 209. Tennessee State is located in 209.
Okay.
Meharry is located in 208. And this 207 is a corridor that goes all the way up. Okay? And you find a higher rate compared to other areas in the Davidson County. Similarly, if you look at congestive heart failure, you again find it is 207, 208, 209, which are predominantly showing higher rates. And if you go down finally to stroke, okay, you find again in the same three zip codes. So what does that tell us? Where are the people going to go? These, according to the census, 2000 census, these are the very low income to middle income neighborhoods. Okay? And it is also aging.
Okay.
So there are two factors that are combined here. If you combine these two factors, you're going to see that certain diseases are going to be more prevalent in those segments of the population. Now, Metropolitan General Hospital is located in 208. That's where Meharry is. If you don't have enough funding for that, for those doors to remain open, where are these patients going to go? So Metro government should be really looking at it, because this is evidence-based. This is evidence-based policy-making decision that people have to, policymakers have to look at where is the mortality coming from, where are the people sick, where do we need to provide services. I am right now trying to develop, in collaboration with other colleagues at Meharry and at Vanderbilt, help them to develop a program to offer services in these three zip codes that we are talking about, where we find a high prevalence of cardiovascular diseases and mortality.
So you think that we can actually cut down on the disparity if you start concentrating? In other words, we've not even concentrated on the issue where the problem really is. Is that what you think?
We have not really concentrated in terms of providing services to those areas, because it is an access issue. how do we access these services? If they are too far away, or if the doctors are gone after 5 o'clock, when the people who need the help, where are they going to go? Who do they see? So consequently, what we find here is the men, and especially African American men, are the last one to seek help.
Okay.
And where do they seek help? When they do, it is in the emergency rooms, when they are very sick. And therefore, when we look at the cost of treating them, healthcare costs, the highest, the most expensive person to treat, according to the data that we have,
is a black male.
Is the black male.
Yeah, that's right.
It is the black male.
And if we could deal with that, you think we could reduce the disparities that
we can, yes, but it will take a lot of education programs. We got to tell them where to go, who to see. We need to bring them into the healthcare system early on. The women get into the healthcare system early on. They talk to their physicians very easily, but it is the men who are the last one to go.
And these are the ones with the high cancer, cardiovascular disease, and stroke issues, and etc.
Yeah, they're all, yes. So it is, we need to focus on those subgroups in order to get them in, if we are going to be really narrowing the disparities. Otherwise, we can keep on giving lip service to health disparity and do nothing about it.
But you're saying that education and access is the most
increasing
important
access
dealing
are
with
the two. Yes, yes.
And good.
There is no reason for us to find, as I have found, that the mortality rate is about 3 to 5 times for stroke only among younger African American between the ages of 35 through 55. This is the period when everybody is busy with their lives. Their children are growing. If you have a stroke
in the middle of,
in the middle of your productive period of one's life, how are you going to take care of the family? But if you don't know what your blood pressure is, that's an educational part. We need to cuff you up, find out what your blood pressure is, put you on medication, control that, because that is the culprit for many of these disorders that we are looking at, or many of those mortality rates that we are counting at.
Cardiovascular disease, stroke.
Yes,
and,
yes.
Now, you mentioned over the last couple of minutes that we have here, Doctor, you mentioned the prevalence of depression. Say something in reference to that, and what your research has been.
There are about 14%, depending upon how you measure it, it's about 14% of the population which is depressed at any given time, okay? Now, I will grant you that this is, I'm not talking about a major depression, but this is the depression which is impacting enough that one is not able to go to work and be productive in their lives. We're trying to handle that through counseling, through medication, all of that through, again, education. We're trying to see whether or not people realize their symptoms. Do they recognize the symptoms of depression? And if they do recognize, can they go to the right place to seek help? And that is very, very critical, because once one of the outcomes of depressive symptoms is people withdraw from the society, from the social context. They don't want to go to see anybody. They don't want to talk to anybody. You know, they're always withdrawn completely. That's one of the problems. So we got to handle that, especially when we are looking at younger people on our campuses. We need to do some counseling programs there for our students.
And of course, Doctor, this is excellent information, but as you know, we've just about run out of time. But let me thank you for bringing that excellent information by, because I think that when we talk about these disparities, what you're telling us now is that we can map this out, and we can determine why these disparities exist, and if we could deal with education and if we could deal with access, that we could go a long way in trying to reduce that. Is that what we're saying?
That's true.
Very
Absolutely.
good. And I think that that's a good piece of education for us. And let me thank you for bringing that information. And let me encourage our audience to tune in again next week for another informative edition of Cummings. Thank you and good morning.